part 3 of 4, HPV in Adolescents. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email or via the webinar's chat box. You can also use this chat box to enter questions throughout the webinar, which will be answered by our presenters at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borsowitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Beth Kruse and Dr. Aletha Akers, today's presenters. Dr. Aletha Akers is a faculty member at Policy Lab at the Children's Hospital of Philadelphia, or CHOP, and an adolescent gynecologist and medical director of adolescent gynecology consultative services in the Craig Dulcimer Division of Adolescent Medicine at CHOP. Dr. Akers is an expert in pediatric and adolescent gynecology. She provides clinical care to children, adolescents, and young women with complex gynecologic care needs. Her research focuses on improving reproductive health outcomes among adolescent women by reducing teen pregnancy and sexually transmitted infection rates by increasing adolescents' access to high-quality reproductive health services. Beth Kruse is a nationally recognized author, speaker, and expert advisor in the field of sexual and reproductive health and family planning, and brings 25 years of experience in providing direct services for low-income and underserved clients, including adolescents from diverse ethnic, racial, and cultural backgrounds. As the lead clinician for the Family Planning Program of Public Health Seattle, King County, Beth is part of a team passionately committed to prevention, education, and high-quality health care for underserved and homeless youth. Dr. Akers and Beth Kruse's full bios are available on ARHP's webinar web pages. We're thrilled to have them with us today, and I will hand it over to them. Beth, you have the floor.
Thank you so much, Jessica, and thanks everyone for coming. I'm going to really try and dash through the introductory background component of this webinar with the understanding that some of you have come to the previous modules before. The HPV prevention and treatment in special populations included a previous presentation by Craig Roberts on HPV in men, and one by John Davis on HPV and sexual and gender minorities. So we'll go through a little bit of the same background, and then we'll take our dive into adolescence with Dr. Aletha Akers. First of all, I want to make sure to thank Merck for their generous support for this webinar and for this series, and see if I can get, there we go, the slides to go. I have no disclosures. Dr. Akers has a disclosure here that you can see on this slide. We'll move along to our learning objectives. By the end of this presentation, you should be able to discuss the burden of HPV infections in adolescents of all gender identities, describe the relationship between HPV and increasingly prevalent cancers, and become familiar with new national guidelines for prevention. And there's a little teaser, some news on the horizon that Dr. Akers will bring up when it gets to her part. We're going to discuss barriers to widespread implementation of HPV vaccination in current practice, which is still a problem. Education, access, consent to care for youth, confidentiality, and administrative issues specifically for youth services, and then look at specific strategies to address them. And we hope you'll bring your questions, strategy questions, to the Q&A at the end. And we want to look at developing these strategies for both youth and caregivers to understand vaccination not only as a part of individual health promotion, but as a way to contribute to the health and happiness of their loved ones. HPV epidemiology. As you know, HPV is the most common sexually transmitted infection in the United States, and nearly all sexually active people will get HPV at some time. Most new infections occur in individuals that are 15 to 24 years old. Among females, the prevalence is about 25 to 27% in the teen years, but jumps up to 45% by the 20 to 24-year-old age range, which is another indication of how very important early vaccination can be. Among men, about 20% of men overall have HPV detected in the anogenital area, which is the penis, the scrotum, and the anus. But there's a really wide range, and that has to do with difficulty in obtaining adequate samples from the genitals and the variation in collection techniques that lead to different rates of recovery. One thing that's really exciting is that we have already seen how much prevalence is declining in vaccine-eligible cohorts. So although this data from the NHANES study did not include a 9 to 13-year-old range, we did see already a 64% decrease in HPV type 6, 11, 16, and 18 among females between 14 and 19 years of age, and about half that rate of decrease among females in the 20 to 24-year-old age group. So what's the relevance to adult health? Published in 2016, just this year, a CDC analysis of data from cancer registries and surveillance programs that showed that of the roughly 31,000 cancers attributable to HPV, almost 80% were attributable to the types that would be prevented by the quadrivalent vaccine. And then an additional 13% would be preventable with the 9-valent or non-valent vaccine. The estimated proportion of cancers, looking a little more deeply, we can see how this breaks down, and that although type 16 and 18 are involved in at least around 50% of the cancers at all the sites listed here, they contribute a clear majority of the cervical, anal, and male oropharyngeal cancers. As a side note, the gender differential is interesting where it diverges, particularly the non-valent sensitive distinction between the genders in anal cancers and oropharyngeal cancers. I think is very interesting and a little mysterious. HPV transmission, very briefly, penetrative intercourse, whether vaginal penile or anal penile, is the primary mode of transmission. Although non-penetrating sexual activities, including oral genital contact and including skin to skin, just even without any fluids or mucous membranes involved. And that is something that really makes transmission prevention more difficult than with some of the other bacterial infections. Risk factors, we're pretty familiar with these. You can look at these in relation to our population of interest today and see which of these factors might be modifiable, particularly in a pediatric population. Under sexual history related factors, recent new partner, onset of age at onset of sexual debut, number of sexual partners, older sex partner, use of latex barriers, and then of course alcohol and cigarette use are also involved in risk factors. This shows us how important it is to start with taking a good sexual history. We're going to have a couple of slides next about taking sexual history, but there's also some great resources at the end of the slide deck. We don't want to spend too much time on that right now, but there's some great further research for you all. So very briefly, taking a sexual history, this is not a new information, but it still may be an area of discomfort for some providers and for some patients, and for some individual connections, the particular individual dyad between that provider and that patient. So it's important to recognize that you can always use your whole team in terms of who might be the most appropriate person or the person that the client connects with the best to take that sexual history. Adolescents in particular can raise some unique challenges, which Dr. Akers will address. But I think that the key point here is that sexual history should be taken from all adults and adolescents, regardless of their gender identity, orientation, or their sexual practices. And this is just one algorithm. This is from the National LGBT Health Education Center. The CDC has another one, so does the AMA. Fenway Health is another excellent resource. All of these organizations and algorithms and recommendations and guidelines have their strengths and weaknesses and can and should be tailored to suit each provider's interaction with each of their clients. For instance, in this one, with number 3, I would ask about multiple partners and new partners. And then as number 4, I would ask about partners' behaviors, which doesn't really come up here. And then as number 5, I would really use this list under number 3 for everybody and not separate that out. But you'll make your own decisions about how you want to focus this. The sexual history can come up naturally when talking with a client as part of the social history. It can also be asked in relation to past medical history. As I mentioned, you can always consider asking if there's another member of the clinical care team that they might be more comfortable with, if they seem to not be interested in talking to you about this. And it's also really important to maintain neutral language when conducting a sexual history and to not make any assumptions about individual sexual behaviors or preferences depending on your perception of their gender orientation, their gender expression. And then all patients, regardless, should also be asked whether or not they have any concerns about keeping themselves sexually safe and healthy. So we're going to go into our subpopulations now. For the purposes of this section, this HPV in females refers to born female, female genitalia, or persons with a cervix. And we want to see here that genital warts can appear really vulva, cervix, in or around the vagina, anus, mouth, or throat. All cases, pretty much, that we can tell of cervical cancer are caused by HPV, and type 16 and 18 are responsible for about 70% of all cases. Really, 66, I think, is how it comes down. The risk factors you're familiar with. This is going to be a short slide for our adolescent population. Basically, women under 21 years, no screening. That is all. And very briefly, no HPV testing for women under or clients with a cervix under 25, and no screening certainly for HPV until age 29. So, but the most important thing for this today, there's a lot of branches to this algorithm, but no screening for women under 21 years of age. HPV in males. The only thing that's different here, really, other than different parts of the genitalia, that's different between males and females, is that older men are as likely as younger men to become HPV infected. And for women, it's definitely younger age groups that are more likely to be infected. We have a little bit of information about the epidemiology of HPV in males. The peak rate is in the 25 to 29-year-old age group. Again, a little bit different from females. We looked earlier in the overview that 20% of men will have HPV DNA detected. One of the things I think to think about too is even if we're just looking at warts and not cancer, when we consider how basically medieval our wart destruction techniques are for folks who do not have insurance or money to pay for the kinder, gentler methods of self-treatment for warts. It's really quite a huge burden on individuals to go through wart treatment if they don't have access to the medications. And then you can see here prevalence of HPV among MSM, very, very important. Even HIV-negative MSM folks have a 60% prevalence, and with HIV-positive folks, it's greater than 90%. We don't apparently have a prevalence rate for straight or heterosexual men. So although this topic was addressed in full in Dr. Davis's webinar, I think a brief review is particularly relevant to a discussion of adolescent sexual health. The most recent survey data on adolescent sexual behavior clearly shows that a significant proportion of sexually active teens are exploring their options. And Dr. Akers will be able to discuss this data in more detail, but just to touch base with this, we have an introduction to sexual orientation and gender identity, or SOGI. This is from the delightfully named Center for Gender Sanity. And I think it's a really nice way to look at these 4 different areas. The top scale, biological sex. Although it's a continuum, most people will be pretty near one end or the other. There are intersex folks that either have neutral features or some characteristics typical of one or the other gender or both. Then we have gender identity, which is how people think of themselves and can't be observed but really only reported by the individual. Gender expression, on the other hand, is what we do as a way of communicating our sense of self to others. And this can vary from an individual from day to day or in different situations. Most folks can identify a range on the scale where they feel most comfortable, but for some people that whole, all the way from one end to the other is their range. And depending upon the day, you may see a very different gender expression. And then sexual orientation, of course, is who we're erotically attracted to. And using attracted to women and attracted to men as opposed to heterosexual and homosexual, because that can be confusing when we get into the different gender identities and expressions. So this is just a good thing to bear in mind. Lesbian, gay, bisexual, transgender, and queer questioning folks, you may see the algorithm SGM instead of an ever-lengthening list of alphabet soup. So sexual and gender minorities do represent a growing and medically underserved population. They span all races, ethnicities, ages, socioeconomic status, and region. Again, adolescents are very likely to be exploring their gender expression and identity. These minorities are very likely to encounter discrimination in society at large and from healthcare providers and from other folks in the healthcare field, not necessarily clinical providers, but also misunderstanding or confusion from folks on the phone, from schedulers, from people at registration. So it really behooves us to all kind of get aboard with this. When folks feel uncomfortable or they don't feel like they have a trust situation, they're likely to remain silent about health issues that are really important for us to know about. And many of us don't fully understand the healthcare needs. So asking clients about gender identity can be a helpful first step in initiating a therapeutic relationship. So you might be thinking at this point that we've sort of gotten a little bit off track, and what does sexual orientation and gender identity have to do with HPV? But basically it has to do with various types of marginalization that affect health. An intersectionality approach addresses the way gender and other social identities affect each other for every individual. And you can see, looking at HPV through the lens of intersectionality, as in this slide, it includes not only gender identity and expression and sexual orientation and sexual behaviors, but also race and ethnicity and socioeconomic status, not only for risk awareness, but screening, detection, and treatment. And you can see how helpful this approach will be in investigating other areas, such as pregnancy, intention or ambivalence or avoidance, substance use, abuse and addiction, violence, and other important public health issues. So looking at women who have sex with women, again, you may be wondering why we're using 5 different terms to describe women who have sex with women on this slide. And even amongst our committee, there was some discussion about this, but basically it's a really good mirror of the confusion in the research, because some studies use the terms heterosexual and non-heterosexual. Some studies use the terms lesbians, bisexual, and heterosexual. Some studies use women who have sex with women, or non-heterosexual or bisexual. So we kind of, when we're looking at the research, we have to use the definitions and distinctions that the researchers did, understanding that these studies may have different definitions of their populations, and some of them may or may not ask the same questions. I think importantly, HPV is the most important and prevalent risk factor for cervical cancer, and that the limited research we do have suggests that compared with heterosexual women, lesbians and other sexual minority women seem certainly to be at greater risk for cervical cancer and may also be at greater risk for HPV, although this is a little bit softer data. For vaccination purposes, there's, again, limited studies on this, but we do have one study that I wanted to point out here from 2015, which shows that between 2006 and 2010, the National Survey of Family Growth sampled 12,000 women, and then they did some follow-up stratified cluster sampling to examine the relationship between sexual orientation and vaccination. And we show a big difference here between the 8.5% of lesbians who initiated the HPV vaccine and then 28 to 33% of heterosexual and bisexual women initiated, even though about 85% of all had heard of the vaccine. So I think this is that's a very important piece there. And then here, moving on to men who have sex with men, very important topic. HPV is super relevant, super important, it's a huge risk factor for men who have sex with men. And I do encourage you to go to Dr. Davis's cached webinar on the ARHP website to find out more information here. But as a brief summary, we have a 30-fold increased risk for anal HPV infection for MSM who are HIV positive. Men who receive anal sex are more likely to develop HPV-related cancers, and HPV vaccination is indicated in MSM through age of 26. So importantly, vaccination, even if it starts a year after sexual activity begins, can still reduce anal intraepithelial neoplasia. Woo! I should stop for some water, but I won't because I don't want to take any more time. HPV in transgender patients, for male to female women, basically transgender females require HPV prevention just like any other population. The vaccine is recommended through age 26. And the neovagina, although it's not a mucous membrane, remember skin to skin is still a risk of infection and HPV transmission. So the neovagina can still be infected with HPV. And of course, oral and anal routes are still affected. Take-home message, all persons with a cervix are at risk for cervical cancer, and when they come of age should receive routine cytology screening per guidelines. Trans men are at risk, and then Pap screening we won't go into in this section because of our age group of interest. And then finally, before we move on to that age group of interest, we want to make sure to recognize as part of our intersectionality lens that there is persistent and pervasive disparity in health outcomes related to race and ethnicity, and this may be particularly true for youth. For Black and Latino men and women in general, there are greater rates of HPV-related cancers and more advanced disease. Disparities in vaccination persist. Unfortunately, we don't have similar research for adolescent males, but we do have some information that initiation rates of vaccine are similar for Black, white, and Latina females, although completion rates are lower for Black versus white females. And then among men, the cognitive and emotional responses to HPV in men study showed that non-Latino Black males were less knowledgeable about HPV infection, and although they were the least likely to identify barriers to vaccination, for instance costs and side effects, they still seem to be the group that were least likely to actually get vaccinated. So some really important work to be done here. And with that, I will pass the baton on to my colleague, Aletha Akers. Thank you so much for your time and attention. And Aletha, off you go.
Wonderful. Well, thank you. I want to, again, thank the funders for this webinar, as well as ARHP for helping to put this together, my co-presenters and the attendees. Beth, thank you very much for that great introduction. I think your point about the intersectionality between different population groups and HPV was really a great one to make at the beginning. And I'd like for the attendees to think about these various populations that Beth has talked about in the introduction. Males versus females, individuals of different sexualities and gender orientations, as well as different racial and ethnic groups. Because as we go through these next few slides where we focus more on the specific adolescent population, many of the issues that are specific to each of those communities are certainly going to come up. So let me give you a quick orientation to the next part of this webinar. We're going to talk about the prevalence of sexual activity among adolescents so that we have a context for understanding why we focus on this specific population. We're also going to talk about the different types of HPV vaccines and go into some more detail about vaccination rates among adolescents, and then spend some time talking about different barriers to vaccinations. But what I'd like to do is just to start with a polling question. This is the one polling question that we will have as part of this webinar. Our question is, about what % of adolescent boys between the ages of 13 and 17 have received one or more doses of any HPV vaccine? So that would be the bivalent, the quadrivalent, or the new 9-valent vaccine. Please enter your responses. Do you think it's A, 30%, B, 40%, C, 50%, or D, 60%? And we'll give you about a minute to respond. Have all of our responses been tallied?
Hi, Dr. Akers. This is Caitlin. Just wanted to let you know that the results are on the screen.
Perfect. Wonderful. So based on your responses, about 71% of our attendees believe that about 30% of males have received at least one dose of any of the HPV vaccines. About 20% of you believe that 40% have, about 5% of you believe that 50% have, and I have a little box in front of 60%, so I can't see what the number is for that. But I will tell you that 5% of individuals who indicated that about 50% of adolescent boys have received at least one dose is correct. And we started with this question because while when the HPV vaccine was initially released for use in 2006, there was a focus on females. We now have indications to use this in males. And while males still lag behind females, the rates of utilization have increased, but there are still some significant differences, which we will cover in a little bit. So let's talk a little bit about sexual activity among adolescents. So this slide is really meant to provide an overview of sexual activity among adolescents. This data is from the Youth Risk Behavior Surveillance Survey that monitors 6 categories of health behaviors among both youth and young adults, including sexual behaviors related to unintended pregnancies and sexually transmitted infections. And what you can see here is that about 41% of U.S. adolescents have reported having ever had sexual intercourse, with a higher proportion of Black or African American students reporting this compared to white students. This rate has actually declined significantly over the last several years and is among one of the lowest proportions in U.S. recorded history since we've been collecting this information. The other important thing, which isn't shown here, is that the rates of sexual initiation are fairly equal between adolescent males and females. So the average age for sexual initiation is approximately 17 for both boys and girls, and there's no differences in the United States compared to other Western developed countries. Another important point here is that the prevalence of early sexual initiation defined as sex before the age of 13 is fairly low. Less than 4% of adolescents report this, although again you can see some significant variations by race and ethnicity. Moreover, you can see that sex with a greater number of partners, so reporting 4 or more sexual partners in one's lifetime, is relatively low. It's only about 12% of the adolescent population who reported having ever had sex. But you also can remember from one of the earlier slides that Beth presented that having sex with a larger number of sexual partners is definitely a risk factor for HPV infection. I also want to take a moment to say Beth had gone over taking a sexual history with individuals, and this is a good point to remind you that it's important to take a sexual history on adolescents. One of my approaches clinically is that I use that as an opportunity for teaching regardless of the response from my adolescents. So even if an individual has never been sexually active, I use it as an opportunity to deliver some brief educational points. So I educate about the importance of the HPV vaccine. I ask whether or not an individual is receiving any sexual education either at home or in their schools. I assess whether they know whether there are other places where they can receive services, whether that be education or clinical services, as a way of providing them with some guidance and information. For my sexually active adolescents, I always ask many of those key questions that were on the taking a sexual history slide that Beth presented. So asking not only have they ever been sexually active, but the genders of their sexual partners, as well as their lifetime number of sexual partners, and assess condom and contraceptive use. Another important thing is for many of our adult patients, they will come on their own, and this information may be obtained in private, but that is oftentimes not the case for our adolescents. So it's really important to make sure that we can obtain sexual histories from them confidentially so that we are maximally able to deliver any indicated educational services or clinical services. And this is true even if you're not in a site where you can provide confidential services. Identifying need and referring to appropriate places is important. The relevance of this to receiving the HPV vaccine is something that we will cover in a little bit when we talk more about vaccination services. So this next slide looks at the sexual contacts of youth who report having ever had sexual contact in the past. So what are their partners like? This data is also from the Youth Risk Behavior Survey from 2015. And this survey assessed approximately 16,000 questionnaires from students attending 125 different public and private schools. You will note here that the proportion of individuals who reported never having had sexual contact is higher than what was seen on the prior slide. That is due to methodological differences. So here the question was asked of individuals who ever reported sexual contact, but sexual contact was not defined, for example, as penile vaginal intercourse, in contrast to the prior slide. And what you'll see here is that among among all of the participants, those who report only an opposite sex sexual contact is about 48%. About 2% report same-sex contacts only, and about 5% report having had sexual contact with individuals of both sexes. And you can see that there are some significant variations by gender, with females being more likely than males to report same-sex contact only, as well as females being more likely than males to report having had sexual contact with individuals of both sexes. So again, thinking back about risk factors for HPV, you can see the importance not just of considering heterosexuality among our adolescents, but also definitely assessing for whether there are same-sex contacts or whether adolescents have partners who are of both sexes or of multiple genders. This slide shows the HPV prevalence and how that has changed in two time periods. The first being the pre-vaccine era between 2003 and 2006. The second being the vaccine era starting in 2009, about 3 years after the first HPV vaccine was marketed, and covering the period 2009 to 2012. Let me orient you to what you're seeing on this slide. First of all, this is showing data from adolescents between the ages of 14 and 19. This data comes from NHANES. The data was analyzed using cervical vaginal specimens from women during these time periods. And what you'll see is that this slide reports the prevalence of having any HPV infection noted, for which you'll see that there were no differences in the prevalence ratio between those two eras. And then the next couple of rows shows the data regarding non-quadrivalent HPV vaccine subtypes. So those are HPV subtypes 6, 11, 16, and 18. And you can see that there are no differences in any of the HPV subtypes, the non-quadrivalent HPV subtypes between those two eras. And there are no differences in the non-quadrivalent HPV high-risk subtypes, so subtypes other than 16 or 18 between those two eras. Similar data is shown in the next two rows. The box in red is really where you begin to see some tremendous differences. And you can see between the pre-vaccine era and the vaccine era, there was a significant differences noted in the 4 HPV types that are covered by the quadrivalent vaccine, with the prevalence in the pre-vaccine era among women ages 14 to 19 being about 12%, with that being reduced to 4% during the vaccine era. And again, that data is only up until 2012. For the high-risk subtypes that are covered in the quadrivalent vaccine, you can also see that there was a significant reduction in the prevalence of HPV subtypes 16 and 18, with 7% prevalence in the pre-vaccine era down to about half of that, about 3% in the vaccine era. So the vaccines really have had a tremendous impact on the prevalence of HPV infections. So how many adolescents are actually being vaccinated? Despite changes in the HPV prevalence among some adolescents after the introduction of the HPV vaccine, you can see that many adolescents still remain unvaccinated. According to CDC's data, the number of 13 to 17-year-old boys and girls who are getting the HPV vaccine increased slightly in 2014. But despite this increase, 4 out of 10 adolescent females and 6 out of 10 adolescent males have not received any doses of the HPV vaccine, leaving them vulnerable to HPV-related cancers. So what are some of the key barriers to vaccinating adolescents? So obviously there are many. There are barriers that may be operational at the parent level, at the health provider level, as well as at the level of the adolescent. In terms of parental barriers, you can see here limited knowledge about the vaccine, beliefs that the vaccine may not be needed or may not be needed specifically among adolescents, particularly those who are in the targeted age group. So starting as young as age 9, but with the target age group of those 11 to 12. In addition, parents may have many concerns about the safety and side effects. A key barrier that has been noted in many studies is parents may not feel that their children need to be vaccinated because they haven't been told that it's recommended by a healthcare provider. And cost is another barrier. The HPV vaccine is one of the most expensive vaccines that has been marketed in history. On the healthcare providers level, there are a number of additional barriers. A common one is really related to financial concerns, which included the cost to parents, but also the cost to healthcare professionals particularly those who may have a primarily adolescent patient population where fewer vaccines are indicated and where the cost of providing a limited number of vaccination services may be a significant barrier to providing any vaccination services. In addition, there may be concerns about inadequate insurance coverage and reimbursement issues for providing these services. Some healthcare professionals, in a literature review that was recently conducted on barriers, thought that the decision to vaccinate was really beyond the control of the provider and cited that parental attitudes and concerns represented a huge barrier. Additional barriers include healthcare professionals feeling more comfortable with vaccinating older rather than younger adolescent males and females. If we turn to look at adolescent barriers, again, the lack of recommendation from a healthcare provider is certainly an issue, as well as lack of parental approval or consent. So this is a very important point because even though adolescents may have access to confidential sexual and reproductive health services, in most states, the HPV vaccine is generally excluded from that. So adolescents still require parental approval and consent in order to obtain the vaccine, as is the case for most others. In addition, many teens have a preference for being seen in teen clinics where, again, there may not be vaccination services offered because the costs of becoming a vaccination practice can be quite high when there aren't a significant number of vaccines being provided. So there was a study conducted that used a nationally representative online survey to explore the experiences and attitudes related specifically to HPV vaccination among parents of adolescent males. And again, we present this data because males are a relatively recent addition to the target for HPV vaccination services. This survey included 809 parents of males aged 11 to 17, and they compared the perspective of parents who did not intend to initiate HPV vaccines for their adolescent sons to those of parents who said that they were likely to initiate or continue the vaccine. And what they found was that about 50% of parents were unlikely to vaccinate and only about 39% expressed being likely to vaccinate. A much higher proportion of those who were likely to vaccinate felt that their health provider was knowledgeable about the vaccine and spent more time discussing it. So, are adolescents getting vaccinated? This slide compares the vaccination coverage by doses for adolescent females and males and compares data from 2014 as well as 2015. This is data that CDC analyzed from approximately 22,000 adolescents that was collected as part of the 2015 National Immunization Survey for teens. And you can see that for adolescent females, the number of those receiving at least one dose of the HPV vaccine of any type was about 60%. Those receiving 2 or more was 50%, and those receiving 3 or more was about 40%. So there are more who initiate the vaccine than who complete, and you can see the total number of those who complete the entire 3-dose series. So for this, the numerator would be those who receive all 3 shots, and the denominator would be only those who received at least 1 shot. You can see in that bottom row that for females, those who complete the 3-dose series is about 70% compared to about 50% for males. In that first row, you can see that the proportion of males who receive 1, 2, or 3 or more doses is lower than that for females. But for both males and females overall, the proportion appears to be increasing with time, though still lower than national goals. So let's talk a little bit now about the different vaccines. So there have been 3 vaccines that have been marketed and made available in the U.S., as are shown here. There's a bivalent vaccine that covers HPV type 16 and 18, the 2 that are most likely to be associated with cervical cancers. The quadrivalent vaccine that covers 16 and 18, as well as 6 and 11, which are lower risk HPV subtypes, more commonly associated with genital warts, as well as the newer 9-valent vaccine, which covers, in addition to those already mentioned, types 31, 33, 45, 52, and 58. And you can see here the approved ages for each of these, which are very similar across the board. The bivalent vaccine is in large part no longer available, and the 4-valent is being phased out in favor of the 9-valent vaccine. Beth had mentioned earlier that I would mention some late-breaking news, which I meant to mention on the previous slide, which is that there is a meeting scheduled for later this week to discuss whether or not there should be changes to the immunization schedule, such that it appears that a decision may be forthcoming that only 2 doses of the vaccine will be recommended as opposed to all 3, but it will likely be several more months before we receive final word on that. So do stay tuned. I want to make a few comments just about the vaccine itself in terms of storage and administration. The vaccine must be stored in refrigerated conditions between 2 to 8 degrees Celsius or 36 to 46 degrees Fahrenheit. It should not, however, be frozen. So this indicates that practices would need to have the ability to refrigerate the vaccines in order, and to have someone who can monitor the temperature settings in order to provide this service. In terms of administration, it should be delivered intramuscularly, either in the deltoid in the upper arm or in the upper anterolateral thigh. The needle for administration is not included in the package, but one can be attached to the syringe by twisting clockwise until it's secure, and then administering the entire ½ milliliter dose. I want to just show you data from a couple of trials that looked at the efficacy of the HPV vaccine, just so you have some understanding about exactly how well this vaccine compares, particularly to the quadrivalent vaccine. I've already talked about the differences in the strains that are covered. This particular randomized, double-blind, phase 2B to 3 study included approximately 15,000 women who were between the ages of 16 and 26. And what they found was that the rate of high-grade cervical, vulvar, or vaginal disease related to the additional 5 strains of HPV that were included was 0.1 per 1,000 person-years in the 9-valent group, compared to 1.6 per 1,000 person-years in the quadrivalent group. So essentially, the 9-valent vaccine was about 97% more efficacious in terms of reducing infection with those 5 additional subtypes compared to the quadrivalent vaccine. In addition, the rate of high-grade cervical, vulvar, or vaginal disease, regardless of the HPV type, was approximately 14 per 1,000 person-years in both vaccine groups, showing no differences there. The incidence of persistent HPV infection related to the 5 additional subtypes was 2.1 per 1,000 person-years in the per protocol population, and 52.4 per 1,000 person-years in the quadrivalent group. So again, demonstrating a high degree of efficacy for the 9-valent compared to the quadrivalent. Another study, which was an international multi-center study conducted to bridge the findings in young women and girls to those of boys between the ages of 9 and 15, similarly showed a high degree of efficacy for the vaccine in young males that was comparable to those in adolescent females. So what are the current recommendations? So it's recommended that adolescents receive the HPV vaccine at ages 11 or 12. The series can be started as young as age 9. It is recommended for females between the ages of 13 and 26, and for males between the ages of 13 and 21 who have not been previously vaccinated or who have not completed the 3-dose series. And again, information may be forthcoming that may change the number of doses. Males aged 22 through 26 may also be vaccinated, and for young men who have sex with men, it is recommended that they be vaccinated up through the age of 26. Although any of the different types of HPV vaccine can be used for routine vaccination for individuals who have not previously been vaccinated, as I mentioned before, then the 9-valent vaccine is now being recommended for those who are newly initiating or who need to be series. In terms of timing of the vaccine, the HPV vaccine is most effective when it's administered before HPV exposure. So that means prior to sexual initiation. Most individuals who will get an HPV infection will do so shortly after initiating sexual activity. HPV vaccine provides a much better immune response in preteens than it does in older adolescents. Again, emphasize why this is targeted towards a younger adolescent patient population primarily. Does the HPV vaccine require a booster? At present, it does not. It does simply require the 3 injections, which are generally given over 6 months. Generally, a dose is given at time 0 with a follow-up in 2 months and then at 6 months. If it's been longer than 6 months, the series can simply be completed. It does not need to be restarted, and that includes if the last dose was several months to several years previously. There is a recent study that was done in New Mexico that assessed primary care providers' perspectives on an HPV questionnaire, and they noted a number of different attitudes regarding the HPV vaccine. The key ones that I would like to emphasize are really that providers really felt that they did not necessarily have sufficient information to explain the vaccine to their families. Although they strongly endorsed the vaccine, many of them did not necessarily prioritize it as much as some of the other vaccines that they might administer. Moreover, many of them felt like parents ultimately needed to make the decision in terms of whether or not an adolescent is vaccinated. And many providers indicated that when discussing the HPV vaccine, they tended to emphasize really the cancer prevention benefits, and they use this as an opportunity to discuss adolescent sexual behaviors. I would say that many of these attitudes have really improved over time, but definitely show that we still have some distance to make in terms of helping providers. This slide shows some suggested language that has been published by the CDC in terms of phrases that providers can use when talking with their patients and families about the HPV vaccine. Primarily, I will highlight a few of these. HPV vaccine is very important because it prevents cancer. I want your child to be protected from cancer. And second from the bottom, we're vaccinating today so your child will have the best protection possible long before the start of any sexual activity. What I'd like to do now is present a brief case study and highlight some key points in this case that really summarize many of the points that have been made during this webinar. This is the case of Martina, a 17-year-old Mexican-American cisgender female, meaning that she was born female and identifies as the same. She is a high school senior. She just finished a swim meet and presents at a school health center with complaints of itching and a rash around the vaginal opening with increased vaginal discharge. She has regular periods, her last one being 2 weeks prior. She's never been pregnant. She's never had a sexually transmitted infection. She says she does not need any birth control, and upon further inquiry, tells you that she has a girlfriend. So what other things might you need to ask Martina? Her age when she began getting her periods, which is 14, her lifetime number of sexual partners, which is 3, the gender of partners she has had sex with in the last 3 months, and you can see she reports female and then also notes both males and females. Gender and sexual orientation of her partners. She notes that she identifies primarily as bisexual. Does she know the types of partners her own sexual partners have had? And she's not fully aware of that. You want to ask her which other sexual behavior she's engaged in, penetrative or non-penetrative. And she indicates that she has engaged in multiple types of penetrative sex, so vaginal, and anal as well as oral sex. She does not know whether any of her prior partners have had any sexually transmitted infections. She denies a history of sexual abuse. She's not a smoker. She has no other major medical problems. And she thinks she's gotten all of her vaccines, but she's not sure. So the point here is really taking a comprehensive sexual history in addition to medical history and other behavioral histories such as smoking history can be really helpful in assessing her overall risk factors for HPV and for guiding your counseling. Similar to many of the points that we've made here, this case exemplifies an adolescent patient who's presenting with symptoms that may be suggestive of a sexually transmitted infection, but whose HPV vaccination status appears to be unknown. And this is really a great opportunity to talk with her about a number of issues, from her sexual behaviors to congratulating her for not smoking, which can increase the risk, for HPV acquisition as well as persistence, as well as to meet all of her needs in terms of talking about her different STD prevention needs, her contraceptive needs, and her need for the HPV vaccine. It also, again, emphasizes the point of the intersectionality here when we think about providing HPV vaccination services. So thinking about our patients in terms of their age, their gender, their sexuality, their race, their sexual identity, etc. I'd like to invite you all, if you have any questions at this time, to go ahead and begin typing them in. I'm going to quickly summarize the key takeaway messages today. HPV is a highly prevalent sexually transmitted infection among adolescents. It's associated with significant cancer morbidity in both males and females. There are several options that are highly efficacious vaccinations for preventing HPV acquisition, and national guidelines recommend HPV vaccinations for both adolescent females as well as males. Rates of HPV vaccination initiation and completion are low in the U.S. among both males and females, and intersectionality between distinct social groups and HPV risk factors, particularly for ethnic and sexual minority youth, must be considered. Pediatricians' knowledge and endorsement of HPV vaccinations can influence vaccination uptake. And we have a number of resources on the final 3 slides for you. These slides will be made available. These include resources at ARHP, which will include an archived version of this webinar, as well as a number of additional ones. And with that, I'm going to turn it over to Jessica, who's going to help us to moderate any questions. I think we have time for a few. Thank you very much.
Thank you so much. Thank you, Beth and Dr. Akers, for that excellent presentation. I will now begin taking the questions that have been entered into the questions box. And our first one is from Shayna, who asks, if the HPV vaccine produces a better immune response in preteens than in older adolescents, is an 11 or 12-year-old a better time to vaccinate?
So this is Aletha. It absolutely is. So adolescents on the younger end of the age spectrum do appear to produce a more robust immune response, which is why it's recommended that that be the target age group. I know that sometimes I've had families who indicate that they were told they should wait until their adolescents are older, but certainly that younger age group is the target age group because that is when you're going to get the most robust immune response. And also remember back to the slide about adolescent sexual activity. Very few teens have begun sexual activity by that age group, so that also makes you much more likely to give someone the vaccine prior to when they are exposed to the virus. Beth, any additions to that answer that you would make?
No, I think that's the only thing I'm wondering is why aren't we recommending they start at 9 instead of 11?
So that's a great question. My understanding is that we have stronger data for a more robust immune response in the adolescents who are a little bit older, meaning that 11 to 12-year-old age group. And there's also some question marks still, even though we do have good long-term data, there's the theoretical risk that the younger you go, potentially the higher the likelihood of needing a booster. My understanding is there may be some data forthcoming in the next couple of years with regards to this question of boosters. But I think that those are really the two. The largest number of adolescents that have been in these trials have been in that slightly older age group, and they've had among the best immune response.
Okay. Okay, that makes sense then. Thank you.
Great, thank you both. Our next question is from Dawn, and this will be our last question, just to give us time to wrap up. And Dawn asks, what do you say to parents who think the HPV vaccine will lead to earlier sexual activity?
Beth, do you want to take that one, or shall I?
Oh, go for it.
One of the talking points that was on the CDC's recommended talking points does address that issue. So there actually have been studies that have been done in order to determine, for example, a number of things related to that. So whether talking to children about sexual and reproductive health issues such as vaccines may lead to earlier sexual initiation, and it does not, as well as, I wish I could remember the journal and the date, but in the last 2 years there's been a publication that asked that specific question of whether vaccinating adolescents against the HPV vaccine may lead to earlier sexual initiation, and it does not. It also does not lead to a reduction in condom use among adolescents once they become sexually active. So I think that's a great question, and that is something that absolutely you can tell your parents. I'll tackle really briefly, I think another question that comes up quite frequently, which is, I don't really need to get them vaccinated because they're not thinking about sex at this time. And the way that I usually respond to parents is I say, that's great. Well, you also wouldn't vaccinate them against the flu once they got the flu. The idea is to give them the vaccine before they get exposed to it. And it's the same thing here. We're recommending the vaccine right now because she or he is not sexually active and is not thinking about becoming so. This is the best time to vaccinate them.
That's great. That's a great analogy. And I think for the, the talking thing as a society, we really, that question comes up, and, just talking to kids about sex make them, and how to protect themselves sexually make them go out and have sex. No, it doesn't. Just talking to kids about preventing pregnancy make them go out and have sex. No, it doesn't. Just getting them vaccinated against cancer, make them go and have, no, it doesn't. It really doesn't. It's just sort of across the board. All of the research that gets done, every time that question is asked, it actually gets answered in the negative, like no extra early sexual activity.
Great. Thanks again, Beth and Dr. Akers, for this excellent presentation. And thanks to all our attendees for joining us. We hope that the presentation and these answers to your questions help you incorporate more intersectional care into your practice and help you raise vaccine awareness among your adolescent patients and their parents. Before we end today's webinar, I just have a few additional reminders. Please be sure to join us for the next webinar in this series on October 31st. Registration is now available on arhp.org, where you will also find a recording of today's webinar within the next week. As a reminder, you will receive an email from Caitlin Borswitz in about an hour containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing the internet browser.